Hello, today we are going to go over HIV. A little bit about HIV and how it came to be. Back in 1981 was the first time it was reported. It took a couple years, actually 4 years, to develop the first HIV testing. Now we have a lot more different type of testing available to us now. Statistically, the WHO reported that in 2020 there was 1.5 million new cases, which is a decrease from 2016 report that had 1.8 million cases. So prevention is key here. Um, Out of 1.1 million people living with HIV alone in the U.S., 15% of them are unaware. Um, Two-thirds of that population are made up of gay men. Um, However, HIV transmission via blood um, has not been reported since 2004, which is a good thing. Bloods are screened better nowadays, and they are screened before administering or becoming available to the hospital to do. And roughly less than 1% is from occupational exposure. Something to consider is that there are quarter about of people living with HIV older than 50 years old. And some of these reasons behind this is obviously unprotected intercourse, um, some misconstrued, or they just simply do not believe that they're at risk. And then there's some social bias toward homosexuality, um, better nowadays compared to back in the days. Yeah. And some of them are continual IV users that's contaminated with the HIV itself. Now, this is a table that you can find in the book 22.1. It is used to classify the infection stages. Notice that the stage one, there's a criteria regarding the CD4 count. So at 500, they call that stage one, and stage two is between 200 to 499. Stage three is what we now designate as AIDS, AIDS. We'll talk a little bit more about that in the future coming lecture slide. So basically, the human system, immune system, actually, it's used to protect us from foreign objects and foreign pathogens. Bacteria, virus, parasites, is to list a few, and some foreign objects, such as like splinters and even transplanted organs. Hence why patients who receive these organ transplants needs to be on uh, immune system suppressors. Yeah. Now, HIV infected individuals, they do not have a fully functions immune system because the CD4 cells are being destroyed. These HIV viruses target CD4s, and once that cell has been compromised, the body attacks the CD4. It's a constant battle within the body. Transmission of HIV virus is through blood, direct blood, semen, vaginal secretions, and also through breast milk from mother to child. Typically, we would recommend a cessation of breastfeeding. We'll talk more about that later. The mode of transmission is having unprotected sex with an infected partner, sharing dirty needles during the pregnancy, delivery, and also breastfeeding itself there. So we'll talk a little bit about this, how it enters the body, but you can read more about it. So viruses, um, just like anything else, that the immediate infection of it causes the body to activate the inflammatory response that draws in white blood cells and other macrophages to the site of infections, whether it's from intercourse or from a cut, a wound. Now, because of these white blood cells that's coming in, the virus itself is able to attach to the CD4 cells and enter in through the body of the CD4 itself. There, it replicates itself by converting its RNA to a DNA, where that DNA then integrates itself into the CD4's DNA, and now it takes over the replication process of that. The more they produce, the higher the viral load, specifically HIV viral load in the blood. Okay, so you can take a look at the figure in 22.1 to get a better idea. However, this is pretty much similar to that there, that you can go through the specific steps. So with the initial infections, with like any viral infections, you get flu-like symptoms, which is very generalized. Body aches, low-grade fever, that sort of things. Inflamed lymph nodes, as you can see, all this symptoms here are very similar to the common flu that anybody got. It takes several weeks, however, to go through a process we call that seroconversions, where the HIV antibodies are starting to really rise up to a detectable level. So during this stage here, we have symptomatic infections. That means that the virus now is not it's not out of the body, and therefore now it's continued to replicate. Now at the beginning, the CD4 levels are very close to normal. That's because the body is able to keep up with the viral production. So it is eliminating the viruses as it's being replicated. We call that the viral set point. Eventually, though, the immune system is unable to keep up with the productions, and then you gradually lose CD4 counts through the year. So your body's still making CD4s, but it's also attacking itself, and that's the chronic effect of it. This process can also take up to 10 years to really see the CD4 counts going lower and lower. Then as the CD4 count declines, we go into the symptomatic chronic infection phase. The body reduces the ability to fight off infections. This is where you're going to have random opportunistic infections that comes around. But some of the non-specific symptoms do occur first, which is those frequent upper respiratory infections. You have the lymph nodes, inflammations, and weight loss here. Now, once a patient is become symptomatic, they develop into AIDS within the next 2 years. So AIDS stands for acquired or immune deficiency syndrome. This is when the CD4 counts drop lower than 200. This is what we call stage 3, if you remember from the table earlier. This is when the count is less than 200 cells per microliter. Some of the common opportunistic infections is listed there. You can see PJP, some macrobacterium, avium complex, that's along the same family class as the tuberculosis. And then we got candidiasis occurring in all those epithelial cells in your mouth and down your throat and whatnot. And so the AIDS itself, the HIV virus itself, also disrupt other organs such as kidneys and central nervous system as well as peripheral. And then you could actually see them have effect on the cardiovascular system as well. Here is a long list of clinical manifestations, aka signs and symptoms, right? Signs is what we can detect and see. Symptoms is how the patient feels and report back. On the left are some of the signs and symptoms that you can see that the patient experienced. On the right side, those are signs that we definitely need to get this patient into the hospital for medical attention. Um, a little bit of reminder is that HIV patients have a hard time fighting off infections. Therefore, high-grade fever can definitely put the patient at risk for sepsis. Here we go. This is some of the manifestation, the symptoms, and the probable cause. So as you can see here, weight loss is worsening of the disease. Fever is it's one of the good indicators of infections. But also, some of these clinical manifestation here can also be side effects of the antiviral medications that we'll be talking about soon. Here is the picture that kind of gives you a timeline of what happens as your CD4 count decreases. These are the different phases. As you can see, early chronic, we have intermittent, and also late. Diagnostic tests here. Nowadays we have home kits as well that we can give out to people, but typically you can come into the clinic and have them done it right there, and it's a quickly you can swab the mouth or take a little bit of the blood and you run these rapid tests and it comes available to you in about 5 to 30 minutes. It's great. Now, if these rapid tests, any of these tests come back positive, we need to have a confirmation laboratory work, which is an antibody assay. Now, here are some of the tests that the laboratory uses, the EIA, and then we also use the Western blot to confirm what the EIA is. It's always a good idea to have two different tests in this manner to make sure that we don't have a false positive or even a false negative. Okay. The Aura Quick is an in-home IV test that one can purchase. They do it and they can see right there. And then, now, how often do we test or even screening? So somebody who had a recent exposure, even if they test negative during that time, they should repeat it in the next 3 to 6 months, because that's really how long it takes for your body to develop HIV antibodies. And then we can go ahead and use the EIA to test for the antibodies and whatnot. Now, antibodies are not really, it's really contraindicated in newborns that less than 18 months because the unreliability of it. They may have some maternal antibodies in there that can cross over, and therefore it's not really something we can use. However, we can use a viral load to test for infants less than 12 months. And these are the infants that their mother positive, and we're testing to see if the newborn has it. And then for individuals who actually have HIV, we routine test it every 3 to 6 months for the first 2 years of therapy, and it's really to see if the patients are adhering to the therapy. Also, the viral is also checked to see the efficacy of the drugs itself too. But two things is, yes, one is to make sure that they are taking their medications and they're not missing doses. And the second reason is obviously to see if the medication works, because now we have many different antiviral drugs out there that's very good at treating HIV. So what is a viral load test? Been saying it a few times. It's measurement of the virus amount in the serum. It looks specifically for HIV RNA levels, right? RNA, remember, RNAs are the free-flowing. Once they get into your body, they convert themselves into DNA using the reverse transcriptase enzyme. But yeah, so the viral load is used now at some tests consider that once you get certain below a number, it's considered undetectable. In recent times, um, low viral loads or absent viral loads, we treat this patient even though this person is HIV positive. But if there's accidentally a needle exposure between the patient and the staff, the hospital staff, we treat it as if that person, the HIV positive person, is a HIV negative, because the likelihood of that getting someone infected with a low viral load or undetectable viral load is near zero. At that point, the clinician can make a clinical decision with the patient or the person who's been exposed, whether to start antiviral, what we call PrEP, pre-exposure, um, or not. But they should have their HIV tests within the next 3 to 6 months, and then 1 year after that. That's the new recommendation here. Now, once the person has been deemed HIV positive here, they do a couple things prior to starting um, the antiviral therapy, right? They have to genotype it because there's certain contraindications. There's certain subtypes that are not that are contraindicated for certain drugs. We'll talk about that a little bit later. And then we also do a CCRS co-receptor on the CT4 to determine if and why a certain treatment it's not working. Now, HIV individuals that has less than 200 cells count here, there are certain risk factors that for IO, which is opportunistic, OI, which is opportunistic infection, such as listed there, the toxoplasmosis and the PCP. If those with less than 50 counts, then we have the M-AVM complex. That's the Mycobacterium AVM complex. But however, if their CD count is low, once they start these antivirals, these CD4 counts can go up, and once it goes up a certain past amount, as you can see right here for the PCP, if it's greater than 200 for 3 months after prophylaxis as well as antiviral, then we can go ahead and discontinue the prophylaxis. And for the MAVM, we can discontinue after the CD4 count is greater than 100. Now, antivirals, currently we talk about 6 classes, but there's over 25 medications available. Now, we want to use a minimum of 3 medications, 2 from different classes. So we'll refer that table 22.3, and that it's in the future slides here that you will see. Now it takes about 6 to 8 weeks for these antivirals to fully work, that it can take the HIV viral load down to an undetectable level. At that point, we want to continue the therapies. Sometimes patients either forget or just simply do not want to take the medications anymore, and hence the reason why we test the patients very frequently. It is critical that we want the patient to maintain taking these medications, because adherence, they must take it for the rest of their life, or else the HIV will come back and it becomes detrimental to our immune system. All right, so some of the treatment preparations we have to address before starting the therapy is that we discussed the advantage and disadvantages of the therapy, side effects of the medications, why they are taking multiple medications, how to reduce potential side effects, and how it affects them, their immune system, and how it's beneficial for their immune systems. Having them understand the therapy increases their likelihood that they will adhere to the treatment plan. Now, this class right here of retroviral medications is what we're going to go over, but I'm just going to briefly touch base with about these, and you can go ahead and read the rest of the lecture slides for the individuals. As you can see here, I'll move forward a little bit, and you can see that we did talk, I did list the medication and also the things that you need to monitor them for. So for the NRTIs, these you can see that the mechanism is very similar with the first two here, the NRTI and the NNRTI. It is to prevent viral RNA to be converted to viral DNA. So some of the most often adverse reaction is listed over here for that particular medication with the lactose, lactic acidosis and bone uh, decrease here, bone density decreasing. So some of the things that we would be monitoring obviously would be the lab work for the pH level. Also, we're going to have them do a bone density test prior to starting as well as intermittently because those are known side effects. Now the next medication here is the injection. These has fewer side effects. Mainly is the injection site that we have issues with. Some of these medications come in combinations, as I'll show you a little bit later. But remember that 3 medication is recommended with 2 different type of classes. Moving through here, some of the side effects here, as you can see, is listed. It's quite abundant. Some of them are very specific. So pay attention to those key differences. But once we get all the way down here, you can see that the medication combinations have make prescribing these a lot more easier. Such as these right here, where they have 3 different combinations of medications that is pre-dose determined, and it's it has less chance of medication inadherence. It's easier to take one pill versus 3 different kind. Refilling them is a lot easier too. But always be mindful that these medications do comes with a copay. You always want to make sure that the reason why they don't want it's not because of copay, but if it is, ensure that you let the doctor know to change to something more affordable. While they are adhering to the antiviral therapy, we need to make sure that they keep up to date with their immunizations. It is really critical because their immune system is not fully functioning. Now, we don't normally give live virus vaccines with CD4 count less than 200. And we don't recommend patients with a CD count of less than 400 be around someone who had the live virus vaccine as well. But these are some of the recommendations that the patients need to keep in mind. The doctor and the nurses will be helping the patient keep these up to date. Influenza yearly, obviously, but also pneumovax for patients with the CD count of 200 or higher to prevent pneumonia and their complications. Now, complications related to decreased immune system is that, here, let me correct this real quick, is that especially people who have 500 cells or greater, they generally don't have any symptoms of HIV related infections, as you can see earlier, weight loss and whatnot. But um, or for females, they may find themselves have higher incidence of vaginal candiditis that comes around even without the use of antibiotics, for example. Um, Now, the next couple of slides here, I'll jump over to this. It gives you an idea of the opportunistic infections that occur with different counts. Between 300 and 400 count, you have oral candiditis and TB and herpes zoster. Um, and at 200, you have incidence of PCP. And so this is it's a good medium to use to help you remember the risks of the IOs for different levels of CDs. One of the things that as we're treating the patient, we need to know that which each increase or certain, actually, I would say the initial increase of CD4 counts give rise to this syndrome called the iris syndrome. It's where as the CD4 is coming up, it's able to fight off the opportunistic infections. But in doing so, the body is overreacting now, and that makes the infection symptoms of that IO even worse for the patient. And it is highly critical that we recognize these reactions so that way we can deal with the symptoms that comes with it. So nursing diagnose is a thing for HIV. 5 of them are listed in your book. As you're taking care of these patients, these are the things that we have to focus on as nurses. For example, knowledge deficit. A lot of people do not understand enough about the disease process, and therefore they can, again, stop taking meds for whatever reason. So we need to provide that. Obviously, they have this new diagnoses. Initially, they may have a lot of anxiety regarding their disease process and things like that. So really focus on the nursing diagnosis here. As we're taking care of these patients, these are some of the things that we must pay attention to as nurses, with the help of these lab orders by physicians, of course. But we want to make sure that temperature are taken very accurately because these are usually the first signs of an opportunistic infections, right? Weight trending day by day or even weekly can help determine the prognosis or the prognosis of the patient or even how well the treatment process is going. Obviously, CD4 count, we're hoping it's going up and viral load goes down. Some of the legal actions, legal issues here is that with everything, HIPAA is the portion of HIPAA, the protected health information or patient protected health information portion of the HIPAA, is that we can't disclose HIV to anyone, not even the spouse, not even their significant others. We can't disclose this to anybody except to the patient or the person that the patient allows us to notify. So although the patient is positive and you cannot you cannot discuss about this treatment process in front of anybody unless you have permission by the patient. Okay. Second thing is you must obtain a written informed consent in order to test for HIV. Yeah, and then we do have a system to help patients about needle sharing partners and whatnot. And the nice thing about California is that adolescents can be tested without parental consent. Helps increase therapy in adolescence. Imagine attempting to tell a parent, the child to tell parents about the reason why they want to be tested. It could be very difficult for the child. Now, occupational exposures, we want to decrease the risk, right? So make sure that you adhere to safety precautions set forth by the facility and using safety measures such as capping the used needles appropriately, especially when you're administering medications to patients who have HIV or any other bloodborne pathogens. Um, for post-exposure, we or the employee who had the recent exposure, they're probably going to be on an ART for 28 days, and then they can follow up to see if they're a need to continue. Like I said, it dependent on the viral load of the patient during the exposure. If the viral load is undetectable, typically we treat that, at least in current recommendation, so we treat those patients as if they don't have HIV, and then the discussion about starting arts or not um, is to be discussed. And check out the UCSF Clinical Consultation Center. You can look that up and then provide that information to the patient as a follow-up, especially those who works an outpatient. Thank you.